exemplars are we gonna use oral agents for? Type 2 diabetes, right? Type 2 diabetes may or may not have insulin, correct? It's one of those things that are similar between the two. They may have insulin, they may not. So these agents work on insulin resistance, decrease insulin production, increase hepatic glucose production. Goal is to increase insulin secretion or improve the insulin reception sensitivity. Oral agents include the sulfonylureas, the meglutinides, the biguanonides, the glucosidases, the thiazolidinones, the glipizide, the glimepiride, all of those different oral agents. There are lots of medications used for type 2 diabetes. First generation, second generation. All of them have the same goal though, of either increasing the insulin secretion, increasing the sensitivity, decreasing increasing insulin production, decreasing the insulin resistance. Major side effects we're looking for. So just be familiar with all of your medications for oral agents. We also have the combination oral therapy. You are responsible for understanding the medications. The non-insulin injectable agents stimulate insulin, the release of insulin, decrease the glucagon secretion, slow the gastric emptying, increase anxiety. Amylin analogs. Here's our start on some examples, charts for you to review. Any questions? So, the amylin analog is co-secreted with insulin, indicated for diabetes 1 and 2, slows gastric emptying, reduces postprandial glucagon secretion, administered sub-Q in the thigh or abdomen, not in the arm. It's pre-supplied in pre-filled pens. The interesting thing, did you guys ever hear the report about what was going on with the use of insulin pens in the VA hospital? It's not, it's unusual to see insulin pens used in VA hospitals now. Do you know why? Because somehow they had the idea that one pen was for everybody. So they would go into a hospital, dial up a dose for patient, whatever. They did change the needle. They did that. That was nice, but yeah. So just insulin, pre-filled insulin pens remind me of that. They are not for use for everybody, okay? Everybody has their own pen, you load them. Just in case anybody did not know that, okay? I just remember that happening. And when I saw that, it reminded me. So it's stored in the refrigerator but not frozen. It should be discarded after 28 days. Dose is done before major meals. Side effects, What's the side effect? What, if I were making a whole, or, putting information in that, what applies to everything? If I'm looking at the oral, the insulin, the oral medication, what do they all have the, potential of causing? Hypoglycemia, right? So if everything that you give to bring down hyperglycemia, every medicine, everything you give can cause what? Hypo. You think that's a big deal that you need to know, and you need to know the signs of, and you need to know how to fix. See what I'm saying when I talk about, you'll see those points, you'll see when you're reading things that keep coming up, keep getting repeated, like, oh, well, that was in that book, and that was in that book, so I guess that might be an important thing for me to know, because I see it repeated a lot. And anytime you have hyperglycemia, anytime you have hyper anything, and you're treating hyper anything, what do you have the risk of doing? Hypoing them, right? So understand it along the spectrum of what I can do and what that will look like, what normal would look like, and when we've gone too far in our treatment or it's not been effective. So hypo is the biggest concern, and risk of severe hypo if it's also given with insulin. To reduce the risk, insulin dose is decreased. Nausea occurs in early treatment. You see nausea as a side effect a whole lot? Yeah. Injection site reactions when you're giving, what are diabetics, especially type 1, doing a lot? They're injecting themselves, aren't they? They don't have a pump. So injection sites are things to be always concerned about. Rotating the injection sites, making sure that there's not redness, swelling. The incretin mimetic example is the Byetta. Stimulates release of insulin from the beta cells, suppresses glucagon secretion, reduces food intake, slows gastric emptying. How many times have I said that in the last 4 slides? Right? Those are the things that you should be keying in on. You don't have to fight so much to remember all this information. Group it together. You're getting a lot of information thrown at you in the time you're here, and a lot of information to absorb. So I just really want you to learn how to absorb it so that you can put it into chunks to remember it better. Not to be used with insulin. Subcutaneous injections in the thigh, abdomen, or upper arm. Should not be used with patients with severe renal impairment. Renal impairment is a big deal in diabetes, correct? Pre-filled injector pens, again, not to be used or shared with others. Initial dose is 5 micrograms twice daily. Administer 0 to 60 minutes before morning and evening meals, never after a meal. Clonidines, metformin, decreased appetite, nausea, diarrhea, decreased absorption of B12 and folic acid, contraindicated in people with failing hearts, liver disease, people who consume alcohol in excess, teach early signs of lactic acidosis such as hyperventilation, malaise, and unusual sedation. And instructed to report these to the prescriber. And if they have lactic acidosis, we want to remove the accumulated metformin. The sulfonylureases or ICE, hypoglycemia episodes, conditions that predispose them to hypoglycemia. Side Side effects: hypoglycemia, more likely in patients with liver and kidney dysfunction. Signs of hypoglycemia. We already been over those several times. Treat the hypoglycemia, notify the prescriber. The glitazines, take 30 minutes before each meal. Should not be taken if the meal is skipped. Drug interaction. Hypoglycemia can result. Combination should be avoided. Food for type 2 diabetic time. Any questions? It's a matter of grouping those medications together so that you know what's treating what. I'm almost out of time here. Insulin. Review the PowerPoints as well. Insulin is required for type 1 diabetes. Can be prescribed for type 2. Different types. Understand the types. Rapid acting. Understand your rapid acting, your short acting, the intermediate. Can you mix the Gargadine galanthus with anything? Very good. See? The things that stand out, that make them unique. Which insulin can you give IV? Regular only, okay? So the basal bolus for the pump is, it mimics how our pancreas works. In the pump, the basal rate gives, they give a small basal rate is being given every hour. And then they bolus whenever they put in their carb count to have a bolus. So that most mimics the patient's true pancreas. This is just another graph about rapid insulin and the onset to see, have in your head whatever way you need to have an idea about the different insulin peaks and their duration, okay? Insulin can be given different amounts. You can mix them together. Whenever you're mixing insulin, which one do you draw up first? Clear. You draw clear to cloudy, okay? Always draw the clear up first. Why do we draw up clear first? Just because they told us so? No. If I draw it cloudy first, right?
You can't get any cloudy in your clear insulin.
You can't tell, right?
Yeah.
So if I have clear, I know it's clear. And if I get cloudy in it, I'm gonna be able to see that, right? So draw up to clear first, clear to cloudy. Do not peak, do not freeze insulin. They can be at room temperature up to 4 weeks. Extra insulin should be stored where? In the refrigerator, shouldn't be direct sunlight, shouldn't be out in the heat. And that's a problem that